would ask, Mr. Chairman, unanimous consent to put into the record my request to Dr. Oz to answer these questions about the fraudsters, which he's been unable to answer for months.
Without objection.
Thank you.
Mr. Smith.
Thank you, Mr. Chairman. Certainly thank you to our witnesses for voluntarily appearing here today. I think we're having conversations that need to be had, and I hope that we can work together for constructive solutions, that we can share thoughtful ideas, that we can recognize that I think everyone on this dais wants our country to do better by the people as it relates to health care. I don't have to tell you, there are glaring problems that we face. Incidentally, Mr. Joyner, thank you for mentioning my bill, ECAPS, Ensuring Community Access to Pharmacy Services. I think that's one way that we could increase access, utilize the expertise of highly trained medical professionals more efficiently and effectively, and certainly as it would benefit the seniors and that access, both rural and urban. And I think of just the, various descriptions of the problem at hand here of high premiums. Now, I had someone describe the situation of the subsidy as we're shoveling government subsidies to paper over a problem. That's true. That it really, I think, conceals the problem at hand. I mean, I think back to before the ACA, the so-called Affordable Care Act, that we had the high-risk pool for those with pre-existing conditions, and now that seems like a bargain compared to what the individual market is having to pay. And there were signs, as all of the debate was happening in the run-up to the so-called ACA, there were warnings that we better be careful in what this is going to do to the individual market, and here we are. Now, we've been learning a lot over the last couple of years, especially, but I'm concerned about just the abuses of the system, and perhaps whether someone might want to call it fraud, someone might want to call it unintentional enrollment. The results are the same. And we know that there's a large number of folks who have recently been eligible for zero premium plans. And recent studies have shown that in 2024, nearly 12 million ACA enrollees, up to 35% of all enrollees in ACA, did not log any claims or use their plans at all during the plan year. Now, I would like to think that there is absolutely no need, although I think it's generally a good idea to at least get an annual physical. But I'm genuinely curious, Ms. Boudreau, do we assume that many folks, 35% of those who are enrolled, are just so healthy that they don't need to see a doctor at all?
Well, thank you for the question, Congressman. As we think about this overall, insurance is used for protection as well as use. So our numbers, I share your concern about potential fraud and catching that and making sure that we have integrity in the eligibility process. Our numbers show that it's roughly around 15% in total that we get our enrollment from the exchanges, both federal and state. The state exchanges we work directly with and do a bit better. But again, we share the issue of integrity, marketplace, integrity around ensuring that eligibility has people eligible for these are in those programs, as well as we think a stable program requires continuous coverage, requires us to be able to deliver preventative care. And so those are all really important pieces of keeping.
Right. Certainly the fundamental concepts of pooled risk are important, and I hope that we can have a good conversation about that too. Now, with all of these debates and various data points circling, I did come across some data here that Mr. Cordani, I'm turning to you to perhaps offer some background and explanation. Now, it seems apparent that in 2024, your company, obviously, as most did, took a rate increase. I think one state under your plan saw a 40% premium increase. Now, in the earnings call on January 30th, 2025, you said that in 2024, that you returned $8.6 billion to shareholders through dividends and share repurchase. That seems glaringly imbalanced in terms of what needs to be done for ratepayers, ultimately healthcare, and certainly shareholder priorities. How can you give us some background there? And I mean, because on the surface, it seems like shareholders receive great benefits, certainly at the considerable expense of patients.
Congressman, thank you for the question. 2 different points. One, I think your initial comment is relative to the exchange business in the year you identified. The year prior to that, we lost a significant amount of money in that specific state because we had an inordinate amount of growth.
Okay, so other states perhaps a lower increase, but certainly
Lower
still an
increases,
increase.
but meaningful increases. Point 2 is we've been in the Obamacare exchanges since its inception in 2014, and we've only been profitable in 2 out of those cumulative number of years. To your broader point, the ability to purchase back stock in that time frame was aided by divestitures of businesses. So we, over the last 5 years, we've divested several businesses, as well as successfully have been able to run our largely employer-sponsored business. So I would ask you to disconnect the purchase of stock heavily correlated toward divestitures and operating cash flow. We have not made money in the exchange business for quite some time. And in the United States, the vast majority of customers we serve are in the employer-sponsored market and in a self-funded way.
I understand that, and my time has expired, but I'm concerned about the employer-sponsored market, especially public sector, where expenses have gone up and coverage has gone down. Thank you.